So I'm Mark Ricciardi. I'm going to help moderate the session with Sachin and Goel to my left. I don't see Scott here, but we got Sarah Palmer, Marvin, and Rahul Sharma as our panelists. We're going to switch the order of the talks today so Sachin can get home to his family. So the first talk is the last one on your list there, A Simple Tip to Ease Mitral Pain, Dr. Goel.
Thank you. Apologize for changing the order. I need to get home. Something tomorrow that I could not get out of. So the talk is a simple tip to ease mitral pain. So the case is a 79-year-old gentleman with severe mitral regurgitation, secondary to a ring dehiscence. He has a history of CABG and MV repair in 2003, ischemic cardiomyopathy, HFrEF, has a BiV device, AFib, prior ablations, also has a Watchman device, CKD4, and has had recurrent heart failure hospitalizations despite optimal medical therapy. Of course, high surgical risk patient with a low EF. And here are the echo images. You can see clearly there is a ring in the mitral space. The LV function is severely depressed, and there is non-cooptation of the leaflets, as you can see on the top right, with this big jet of MR, which is directed through that posterior dehiscence, which you appreciate in the 3D images in the bottom, both in the 3D and the 3D color. So this is the pathology that we're dealing with. He's, again, as I said, a very high surgical risk with STS score of 8 or 9%. So what do we do here? Surgery, I don't think is an option. Transcatheter mitral valve replacement with a sapien in ring, or a dedicated TMVR, or mitral edge-to-edge repair. So we have a non-con CT. He's kidney function is not great. This is an incomplete band. The details of the surgery from Hawaii 20 years ago were not available. We were not going to do a valve in ring here. This was a dehist ring posteriorly, and there was non-cooptation of the leaflets. So we thought that mitral edge-to-edge repair seems to be the most logical choice here. The posterior leaflet was plenty long at 1.2 centimeters. You can see the LV is significantly depressed. And again, the color 3D shows that MR. But the reason for the MR is predominantly the non-cooptation, and it is directed posteriorly through that ring. So the main challenge here is, how do we approach this? Normally, as you know, when you do mitral clip, the clip is perpendicular and comes down straight. Well, if we take that approach, then this is going to, the clip is going to interact with that dehist ring, which is not in its usual position, but more towards the center of the valve. So there is a need to create an aorta hugger here so that we can come parallel to the aorta and avoid interaction with that dehist ring. And that is really the idea in this case. So, you all do mitral clips, or people who do mitral clips are aware of the use of the plus knob and the minus knob on the guide. Most of the times we use the plus knob when we want to stand the clip up, when it is an aorta hugger, which happens sometimes. But here we want to create an aorta hugger, so we're going to use a minus knob so that we can deliver this clip without interacting with the dehist ring. And that's really the point of the case. The transeptal puncture is usual, 3D TEE to guide the clip down. As you can see, the clip is coming straight down. And we add, this is before the minus knob. It is coming perpendicularly. It's going to interact with that dehist ring. And then in the next slide, you'll see, this is a picture from Raj Makar's paper from a few years ago, showing the different knobology and how this works on the dry model. And but the bottom line is that the negative knob will straighten the steerable guide catheter and move the system anteriorly and create an aorta hugger. This is not something that we use commonly, right? Most of the times we use the plus knob to stand it up, but here it's the opposite. So here is the MPR. After we add the minus knob, create the aorta hugger, and you can see that the clip is, the system is parallel to the aorta, and it's directed at the opening there without any interaction with that ring, the dehist ring, which is in the center of the valve. And as you can see in the right-sided MPR, we are crossing there without really any interaction with that dehist ring quite comfortably. And then we use the usual 3D to orient the clip. On the left side, you can see the clip is slightly canted. We clock it a little bit. We can't clock it anymore, but it's pretty perpendicular there. And rest of the case is pretty straightforward. Sorry, let me go back. Sorry. The upper panel is not playing, but the point is, we've grasped the leaflets successfully there. We see the grippers bouncing, and there is, mild residual mitral regurgitation, as you can see in the color images in the bottom. And here's the corresponding 3D color. You can see tiny amount of MR compared to what we started with, which is still, directed through that dehiscence posteriorly. The gradient is 4 millimeters of mercury, and again, this is the final result with the clip. And this is the 30-day follow-up echo. Again, the EF is down. The clip is well attached. We have a double orifice valve and mild residual mitral regurgitation, and the patient continues to do well. So the key learning really was MTR in patients with annuloplasty ring dehiscence is feasible. Depending on the dehiscence, such as in this case, steering with the minus knob to create an aorta hugger may be necessary for optimal steering, leaflet grasping, and avoiding interaction with the dehisced portion of the ring. Thank you.
Great case. So just a quick question, then definitely I see a lot of smart and experienced people in the audience as well as our panel, but there's other ways to get an aorta hugger. Did you do your transeptal puncture where you normally would, or did you try to go to the superior anterior in your? So
we did go a little bit superior anterior, not the typical posterior and high, but we still needed that negative knob.
Okay.
So Sachin, another question. Typically when we use your plus knob, we tend to go medial. Similarly, do you have to correct for going lateral when you use the minus?
A little bit, but not quite as much. I haven't used the negative knob that much, to be honest with you. As we all use the plus knob much more, you're absolutely right. We go posterior and medial and we corrected. But with the negative, we didn't go very much lateral, to be honest. It was just helpful to lay this down and then cross without interacting with the ring, since that dehisced ring was right there in the middle of the valve.
I would just say that I love adding the minus to the guide because a lot of times if you look at the orientation of the coaptation planes, the posterior leaflet is often pointing posteriorly, and it just helps get under it a little bit better. I first saw this in Japan like 5 years ago, and everybody in the audience was dumbfounded because he could not grasp the leaflets. As soon as he created an aorta hugger, it matched the coaptation orientation of the leaflets, and then it just fell right in. And I think matching it like you did, it was beautiful.
So other than this situation, Paul, are there other situations where you use it?
Anytime the valve is pointed posteriorly, you can create minus and match the device to those coaptation planes. And it allows the leaflets to sit flatter in the device, and I think that really helps with bringing them together to reduce the MR.
Any other thoughts? Audience, panel, all good?
Sometimes you need it to lose height. In certain situations, but usually that's not the issue.
Right, and it, in my experience, definitely pushes you lateral. It's anterolateral, posteromedial. So, cool, good. All right. Second talk is we got a pinch hitter here, or do you want to go up? Are you up?
Yeah, it's me.
What is you?
I think Marvin
it's not a
was
pinch
first.
hitter. Good. Marvin's going to come up. Dr. Marvin Ang, repair of complex mitral pathology.
All right. Well, I want to thank Paul for inviting me again this year. It's a fantastic meeting, and I just love how we get into the technical details of how we do these great cases. These are my disclosures, and just quickly, this is a 61-year-old woman who was hospitalized at an outside facility and transferred. Her chief complaint was worsening dyspnea and volume overload. And as you can see, when she came to the hospital, she was a little unstable, a little hypotensive and tachycardic, clear on atrial fibrillation. And prior to transfer, they treated her, for what they were worried about as a COPD exacerbation. But her symptoms appear in the context of prior mitral valve surgery, prior PCI, AFib, hypertension. She's an active smoker, and she enjoys her occasional cocktails, so much to the point where I think it's injured her liver. And then when she was transferred, she was on a heparin drip, but was noted to be taking apixaban, pre-hospital, and a beta blocker, some other meds, diuretics, and then a transthoracic report, described a mobile mass in her mitral valve with preserved EF. And notably, when she presented, she had a leukocytosis, elevated lactate, elevated liver enzymes, and an elevated INR. You can tell she was obviously congested. So we went straight to a TE, only because we wanted to get to the bottom of what this mobile mass was on the mitral valve. So let's take a poll. Like, what do you guys think this is?
Yummy.
So who thinks it's a clot? All right, you think it's a clot. Who thinks it's a veg? All right, everyone thinks it's a veg. Well, at the end of the day, we just couldn't tell.
We have a third vote here. We have a
Third possible, ruptured pap muscle head.
Ruptured pap muscle? I don't know, it's a bioprosthetic valve.
Oh, this is a biopsy.
Yeah. This is a 31 epic. So, we couldn't tell. So the patient was getting like heparin and antibiotics at the same time. Everyone's just hedging their bets. T mean grade was 9. So she had heart failure, and an ultrasound showed that she had a fatty cirrhotic liver. CT surgery was like, well, the MEL's 22. We're not going to cut this. And she has persistent symptoms. Cultures are negative. All right. So what should we do?
Suck it out.
All right. Paul knows how I think. So anyway, so we had previously done a veg/thrombectomy, and one of the key points to trying to get an angiovac, or at least for me, into the left atrium is, I guess you could do it two ways. You could either take a 65 centimeter sheath, that would probably work, but I personally like using a shorter sheath and balloon-assisted tracking across the septum. So that's the 24 French, the real angiovac, and that's like a 12 or 14 balloon, and we're just tracking across the septum. So we love the bat, okay? And then here we are using some NPR, and we're vacuuming this thing as well as we can, and you can see on the right panel. That's just, after extracting as much foreign material as we can, you can see that that's as clean as I can make the leaflet. There's still a little subvalvular grummus, but this is what we extracted. Which, by the way, to our surprise, was tissue culture negative. So either it sterilized by the time we got to it, or it was just clot the entire time. Nevertheless, so patients, post-angiovac, clearance of the thrombus, still has a mean gradient of 9, so it actually didn't help that much. And to your point, Nadira, we did a plane emitter area, and it's 1.3. So we felt that this still warrants further treatment. Discharged the patient on Coumadin, and we did this CT analysis. So you can see that the Neo-LVOT is 86. The skirt Neo-LVOT, I know it's cut off, but it's like about 205, 206. So it's high risk for LVOT obstruction. Although there is one point to make is, this is a porcine valve, so it's an epic. So, when you do TMVR, the leaflets actually don't make it all the way to the post when you inflate the valve on the inside. So the calculus for LVOT obstruction is a little bit different. But because the Neo-LVOT was so borderline, like the skirt Neo-LVOT was just 200, we still felt compelled to do some Neo-LVOT modification. I guess this is a theme. I guess I'm copying you, Paul, but we wanted to do more batting. We did an electrosurgical cross using a Stato wire, and there you can see us. We're crossing as close to the base of the leaflet that corresponds to the LVOT as possible, and we use a coronary balloon and use a balloon-assisted tracking to get across the leaflet, and it's a 7 French GR guide. Follow that up with a peripheral balloon, and because the leaflet's not that long, you just kind of obliterate it from inside out, and you can see on the NPR we've kind of created this cleft that's leaking through, and just like a lot of other cases here, we preemptively place a balloon pump, and then we follow that up with the implant of a 29 Sapien. So the there's a little bit of a waste at the the atrial end of the valve. So and by the way, after we do this, there's no hemodynamic compromise. LVT obstruction, wasn't a factor. So we were relieved for that, and then we follow that up with a post dilation with a 28 Trudeau balloon. I think we post out of the valve. I don't think we ever really fractured it. The idea of the epic valve is 27 millimeters, and we're able to relieve the mitral valve stenosis. So basically, in summary, left atrial thrombectomy is feasible. I routinely use cerebral embolic protection, and then there's this controversy whether or not you want to return the blood to the venous side versus the arterial side, if you want to avoid hemodynamic compromise, and I typically return to the arterial, but if large bore access isn't is a problem, then you can probably consider returning to the venous side. And blue assisted tracking, I think, is just a fantastic technique for all the following things. Getting the angiovac across, and then in this case, doing the Batman technique with Neo-LVOT modification. Thank you.
What was the size of the peripheral balloon you used?
Actually, I used it to match the septotomy I like, so I used a 14. I just wanted to minimize the exchanges.
Marvin, great case.
Sorry,
Sorry, go ahead.
Sorry, go ahead.
Were these two procedures done at the same time, or these are staged?
They were staged. So, after we did the angiovac, we discharged her on warfarin for a few weeks and then brought her back.
So the presumption is that this was thrombus, right? So, because your cultures were negative, or you think this is healed endocarditis, or?
We think it was thrombus. I mean, the histology and the cultures were more consistent with that.
So are you going to leave the patient on warfarin or anticoagulation indefinitely, as much as you can?
Yeah, as much
despite
as
the
she can
liver?
comply with.
Marvin, great case.
Yeah.
She's 61, you said, right?
Right.
I may have missed this in your intro slide, but what was the reason that you guys didn't consider second-time operation?
Yeah, the surgeons calculated a MELD score of 22.
MELD score, the liver disease.
Yeah.
And so on the panel, who would have done the balloon modification versus like a typical tip-to-base lampoon?
I mean, I would have taken her to surgery, I think. I think for these people that show up with, questionable endocarditis with a bioprosthetic valve, I mean, you have to assume it's endocarditis until proven otherwise.
Yeah.
She's 61, now she has a 29 and a
You still may have
surgical
an
valve. I don't know
opportunity
how long that's going
to
to
take
last
her to
her.
the OR.
But I don't know how to calculate a MELD. Maybe that's,
I have no experience with a Batman, so I would have done a tip to base, but after this meeting, I'm really looking forward to trying the Batman.
You think it's easier?
Well, sometimes with the tip-to-base lampoon, I question whether or not we ever really get to the base. So, I've seen a couple of cases where I wasn't quite satisfied, and then I really wanted to obliterate that leaflet. So I wanted to kind of deploy through like the cleft and really shove everything to the side. Whether or not it does a better job of clearing the Neo-LVOT, I don't really know, but I've been on this kind of streak, and I think I've done like maybe 3 or 4 cases, and like the Doppler the next day, like there's no LVOT acceleration. So I've been pretty satisfied with my results so far, and I've been doing lampoon, for a while.
And
I think I have to agree with Sarah that you just mooted this case down the road. This is something I would do. I'd move it down the road so a board would have to do a board would read you like 5 years
You know what? That's fine.
Where you traversed the leaflet, did you purposely try to go a little more towards the tip just to make sure, since you didn't absolutely need a perfect modification here, right, given the Neo-LVOT skirt, or did you just hit it anywhere?
Actually, I've tried to get as close to the base as possible.
Yes, and the balloon you think would rip all the way because it's a fairly short porcine leaflet.
Yeah, it's a short porcelain leaflet. So I think, RT, pretty much demonstrated like, there was a big cleft in that leaflet afterwards. And, I have a few more cases that kind of demonstrate that.
14 balloon.
Yeah, I used a 14. And, you could have used a 10 or, I think you just need enough to deliver the valve.
Yeah. It's easiest, I think, just to pick the balloon for septostomy, right?
Right.
So it's a 14 by 40 atlas for the septostomy.
Exactly.
You use the same one for the balloon septostomy,
Yep.
or for the valve.
Did you rapid pace also like Paul's case, or do you do that?
In this case, I didn't. And then, the cases I've done more recently didn't require it because most of the leaflets were stenotic. So, they were just, they were frozen. So I didn't have to do that. But it's not the first time I've heard of rapid pacing for when you can't get, perpendicular trajectory.
You have a question there? Yeah. Comment?
Well, are you talking about like why you use the larger balloon? Well, I wanted the valve to get through the leaflet, because otherwise I wasn't confident. I didn't want it to get caught, because even if you use a 5, there's no, that sapien's not gonna fit through it. It goes through a 21 or 4 French sheath. Maybe, as long as I'm confident that the entire THV is through the leaflet, then I'm satisfied.
The truth is that if you can't get the THV across, you're kind of screwed. This is not like a rewire situation. Once you're in the left atrium.
So I will ask the provocative question another way. Why not do this more frequently than what we're doing now with I think like we're all losing Lamboon depending on Neo-LVOT and all of that. This seems to be more reproducible than Lamboon, and as you mentioned, you're already anyway going to use a 14 balloon anyway. Should we do this more frequently? And why not?
Yeah.
Marvin?
Yeah, so, that was one of the, that leaflet wasn't as tough as some of the, the bovine leaflets, degenerative beef leaflets that I've had to cross through, and those were difficult. So the answer is they're not all that easy, but it's doable. Whether or not it does a better job with the Neo-LVOT, I'm not sure. I do remember, participating in the Lampoon trial, and some of the people still had LVOT gradients. And we don't know if it's because, whatever LVOT that we estimated was, overestimated, on the CT, and we didn't get as much as we thought, or maybe the Lampoon wasn't as effective. I'm not entirely sure. And by the way, I've also heard of, prosthetic leaflets cracking or fracturing, and, we use the Sentinel, but, can that happen? And will creating debris be a possible complication? I'm not sure.
So yeah, technically this seems easier than Lampoon, or tip-to-base Lampoon is easy, but the classic Lampoon, can be technically challenging. The biggest question, obviously, is is the risk of embolization and stroke going to be lower, or what is the risk of stroke with this compared to a Lampoon? Yeah. I think that's what it's going to come down to. Yeah.
Or is it even different? Maybe they're the same. I know
Cleveland Clinic has a series that is about to come out. I don't know. They have 15 or 20 cases. I don't know what the data are, but I think we need more data, obviously, with these cases.
We don't know what the incidence of malposition is with this technique. So.
For like a MAC, I would consider it. You did one for a MAC case, and I think it's it's got some feasibility, especially when the leaflet's long.
you're removing the leaflet essentially.
Right. And that's what's so enticing about it.
Right.
Good.
Yeah. I mean, I don't know. I mean, those are all, this is what we dream of right before we, those are like, you know, the 1 second right before you play the case, those are all the thoughts that race through your head. And we just, and, you know, fortunately for us, it's worked out so far.
Great. That was a great one, Marvin. Thank you.
Thanks.
All right, so next up we got the pinch hitter. This is Dr. Paul Sorajja, who's going to fill in for Dr. Saifi, talking about imaging for difficult transcatheter mitral.
Thanks, Mark, and
Or
good
fistula.
afternoon. So this is a quick case that I just put together because Lucy Safi was graciously stuck in Newark and could not make it. So, oh, I need the advancer. Who has the advancer? All right. All right, so this was a 64-year-old man, and the question was the leak. He had double mechanical, aortic and mitral, and he actually had 2 pump runs, and I was called to the operating room because despite 2 pump runs, they could not get this leak to go away. So I was called to the OR and said, could you look at this echo and see, do you think you could potentially just wire and plug this because I don't want to do another pump run because it's frustrating us. So I was like, sure, all right. So here's the echo. And honestly, I was like, well, okay. Doesn't look too bad. I certainly don't think it's worth another pump run, especially since you've already tried twice here. But you know, I'll see him in clinic, and we'll discuss it. So he eventually recovered from his surgery. His sternotomy healed, and came to see me, and he was quite short of breath. And honestly, a lot of the echoes looked kind of like this. It wasn't really too bad. And I said, you know what? We just need to study you. So we brought the patient to the lab, and I had already done a CT scan. I knew where this leak would be, and it was interesting. It was actually quite a bit. And so we thought, okay, this is probably something that could make somebody symptomatic. And so we decided we were going to close it. So here's the situation. You got 2 mechanicals. It's an aorta to LA fistula. Aorta to LA. Who's seen one of those? Yes, 1? Okay. Well, not at surgery. That doesn't count. Okay, all right. So this is my first, and so I've done a lot of PVLs, but this is my first aorta to LA. I thought, wow, this is actually kind of interesting because how am I going to get to this? Well, I could go retrograde, but then it could be a little difficult to wire. So this is what I planned. A telescope multi-purpose with a 5-French diagnostic, crossing with a Roadrunner. We'd go transeptal with an inferior puncture, and then through an Agilis, place a gooseneck, snare the wire, and create an AV rail that way. So the rail went aorta, LA, out the vein. And then the question becomes, okay, so once you have this rail, which allows you to only cross it once, which way do you place the delivery sheath? Do you go around the arch, or do you go right atrium, left atrium, back up the aorta? You go antegrade. Yes, Rahul.
I've never done an aorta LA, but just based on my PVL experience, what I would say is that you go based on where you felt the least resistance as you're sort of advancing wires and advancing your 5-French diagnostic and your telescope guide. If you feel like aorta to LA went smoothly, try that.
So what I figured is there's one turn. If I go retrograde, and if I go RA to LA up to aorta, there might be more than a couple of turns. And so I thought, well, because I've only done this once, I'll try what I think might work. And so we went retrograde. So here's how it was. So this is a wire. You can see on the left-hand side, the wire is crossed, and you can see it looping in the left atrium. There's a transeptal. The Agilis sheath is already in the LA. I don't have pictures of the snaring, unfortunately, because I just put this together just a couple hours ago. But the Agilis is there. We use a gooseneck. We grab the wire, and then we gently pulled it to the vein, and then had both ends for our Kellys. And then this is the sheath coming up around the arch. So this is a 7 French flexor. So the flexor's coming around. You'll see it come up here. If you watch carefully, that's me saying, Echo, could I have your probe up just a little bit? Yep. And so here comes a sheath around, and you can see the end of the wire, which is snared through the Agilis there. Okay. And then it was actually a pretty straightforward procedure. So after that, it was an 8mm AVP2. So there we essentially put a couple of discs. Initially, the first passage, you can see 2 discs are on the LA side. I didn't like that position, and the color, there's actually still quite a bit of MR. Oh, sorry, well, what do you call that? AR? Is that AR? That is AR. So it's AR into the left atrium, right? So there's still quite a bit of AR into the left atrium. So then, because of the rail, we easily went back over the rail, recaptured, repositioned, and then put the plug such that the 2 discs were on the aorta side and the 1 disc was on the LA side. And at that point, it actually was much better. And you can still see the wire that's still across there with the plug next to it in case I needed to put in a second device or recross it again. So that repositioning was aided by the rail. We then go REO here to kind of verify where we are relative to the mechanical valves. You can see the aortic and mitral there. Very important to make sure we're not impinging the leaflets as we're doing this. Both valves are functioning very well. And then this is the final release. And so you can see here, whoops. So is there somebody we can play that? There we go, okay. You can just see that it was really, really nice. And so it turned out quite well. So take-home points. First, sometimes these PVLs can be underestimated. He did really well after we corrected this with that simple plug. I think, especially when you have prostheses and if they're mechanical, there can be a lot of acoustic shadowing that can make it hard to see regurgitation. And it became really obvious when we did his aortogram. I like the transeptal AV rail for this. Again, this is an N of 1. This is not a common procedure by any means. The retrograde approach worked really well. It was a simple flexor catheter. We had the rail as an anchor wire in order to recross and reposition, and also provided great support. So thank you very much.
Great case. So Paul, just for some basics, tell us what sheath size you used and which wire was an 018, 035.
Yeah. Good question. So the Roadrunner is an 035. It's an exchange length, 300 centimeter, so it's got plenty of length. If you want to leave the rail behind, you have to use at least a 6 French flexor. A 6 French flexor plus the rail will allow a 12mm AVP2. Yeah. So you just remember that math. 6 flexor equals 12 plus rail. Yeah. So I use a 7 flexor because I actually thought I was going to need a larger plug. Right. That's how I chose it.
And what was the length of the flexor sheath?
So that's the other important point. It has to be short enough to allow the cable of the AVP2. So these are 90 centimeter flexors. And so if this person, that's another good question. So if this person had been really tall, we would have been forced to go antegrade. Yeah. It would not have been long enough for the retrograde approach.
Yeah, there's a 6 French 110, but 7 French you're limited in length and stuff.
Yeah,
and then delivery. Yeah, great case.
Yeah, so that's a great question. So I've had hemolysis with VSD devices because the mesh is different with the VSD device. It's quite rough, I think. Plus, it requires a larger sheath to deliver. So I try not to use VSD devices unless I have to. AVP2s, I actually have not experienced worsening hemolysis. Have I been in a situation where I have not cured hemolysis? Absolutely. but I haven't been in a situation where the AVP has made it worse. But I have with VSDs. I don't know what others have had with experience with those devices. So.
Yeah, I mean, it's weird. I have had an experience with incomplete closure or hemolysis with AVP2. Sometimes I like to use amplex duct occluders. And then just, for the length challenges, I didn't realize until a couple years ago, but there are glide wires that are like 400 centimeters. So if you ever worry about the length issue, like that takes care of it.
Yeah, that's a great case, Paul. I've had one case of a VSD occluder. I don't like to use VSD occluder for the exact reasons that you stated, and that patient ended up having hemolysis and had to have surgery. So that case that I showed at the previous session and the VSD are the two patients that had persistent, unrelenting hemolysis needing surgery. Question about this case, real quick. What was your buddy wire or the rail?
It was the same flexor. So because we had exteriorized through a dry seal, and we were able to go over with the flexor on the rail, and then just leaving the wire in place, we could put the plug alongside it.
Just alongside it?
Yeah, it was alongside, yeah. Sarah, do you want to comment on pump runs and leaks and the double mechanical?
I was just trying to figure out how this leak occurred. I don't think this was one of my...
No, it wasn't.
Okay.
Yeah.
I mean, yeah, it's hard to imagine.
The only thing I can think is that maybe the aortic cannula could be a little deep.
Mm-hmm.
We do it like a cannula enlargement. You
Yep.
feel off a little bit of left atrium.
Mm-hmm.
It's hard to get into it, but
Yeah.
right in this case, so if it was completely a little deep, then stitches would take it faster to roll.
Yeah.
Yeah.
I think sometimes the double valve, the mitral can distort that too, and so doing the aortic afterward, I mean, maybe, but I hope I don't have this problem, but if I do, it's nice to know you can fix it.
That's fine. Yeah. So, I mean, the only other way would be, honestly, an MRI for quantitation. But honestly, the easiest thing, we just do an aortogram or an LVgram. I just think that the fluoro is so easy to overcome some of the spatial limitations. And my third PVL case ever in my life was 2005. And it was an exact same scenario. And so that's always imprinted on me that the patient had mild AR. Oh, we knew it was LV to aorta to LA. We knew it was there. Yeah, so we knew that ahead of time. But I just didn't know how severe it was. Huh? Well, like I said, it's my one and only. But that's why we have this meeting, right? So.
Excellent.
Right, thanks, everyone.
Good job. Okay, next speaker is Rahul Sharma, and the title of his talk, I don't know about the syntax here. I wish I were a surgeon in this transcatheter case. Something like that.
Just in this transcatheter.
Okay.
So good afternoon, everybody. Thank you to Paul and course directors for having me. Paul, I want to give you a special thank you for giving me a chance to really show this case. Everyone's shown like the most amazing cases, and now I'm going to show you a case that just hurts my soul. So this case is, I think, from a couple of years ago. I have some disclosures which you can review on the website, I guess. Okay. So this is a 90-year-old male hospitalized for 3 weeks of progressive shortness of breath. He has never before been seen by a cardiologist. He never had any reason to be, according to him and his family. He says he's been getting progressive lower extremity leg swelling, can't lay flat, can't sleep at night, can't breathe. And one of the biggest things he said when we met him was, I cannot ride my bike anymore. And I clarified with him, we're talking a stationary bike, something you're just laying down and pulling the pedals. But no, that he was riding a bicycle in his neighborhood, locally, around his house, around his streets, up until about 4 weeks or so before presenting. So these symptoms had really debilitated him, and he was not, your typical 90-year-old. He was on 6 liters of oxygen. There's some other past medical history, but generally a healthy guy. His dementia was, you could take my word for it, very mild, but he was diagnosed with some cognitive impairment. His labs were notable for a NT-proBNP of 20,000. It's cut off there by the camera. Hemoglobin looked okay, mild anemia, platelet count was okay, some renal dysfunction. His x-ray showed bilateral pulmonary edema. His transthoracic echo showed severe mitral regurgitation, which appeared to be primary MR, at least from what we could see. He had normal coronaries, and we did a right heart cath on him. His wedge pressure was 40, and he had a V wave of 70 with a PA pressure of 66/38. Normal coronaries. So the clinical challenge was this. So this is the only TEE this patient ever had, which was the TEE on the day of the procedure. Why did I choose not to do a TEE prior so that I could plan everything out? Well, I thought he's 90, he's on 6 liters of oxygen. If he has respiratory issues when we're doing the TEE, he's going to end up getting intubated. Let's just go in and just do this on the spot. So we had extensive discussion with the family. Should we even do anything at all? Should we pursue palliation? You know, obviously medical therapy wasn't working in the hospital for the few days that he was in there before meeting me. So the family was very adamant, as was the patient, that they wanted to try any possible chance to get him back to where he recently was in terms of his activity level. So based on that, we took our marching orders to try to see if we could repair this valve with edge-to-edge therapy. So he went under anesthesia, and this is his TEE in the actual mitral clip procedure. And what you will appreciate as the case goes on, in case you don't see it already, is that there is bileaflet prolapse. And depending on what point in which the valve you look at this, if you look at the valve medially, the prolapse is more with the posterior leaflet. But if you look at the valve right down the center, it's obviously more A2 prolapse. And then laterally, it's a combination of both. And these kinds of cases are challenging in terms of where you're going to put your first clip or what strategy you're going to use. But there's just tremendous MR here. And image after image kind of drives that point home. His valve area was 7.8, so I felt comfortable saying that obviously this case is going to require multiple clip devices. And the 3D image on the left shows the varying degrees of A2 prolapse as well as prolapse in other segments such as P3 and P1. So the slide is supposed to be resolution of the challenge, but obviously, as I alluded to earlier, this case did not go the way we wanted. But we attempted to resolve this by edge-to-edge therapy. I first started with an XTW clip, and my plan was to go right down the middle to try to get that A2, P2 segment where there was significant prolapse of A2. I could not grab the valve at that point. I also tried giving adenosine. We tried a number of maneuvers. We had excellent height. I think our height was about 5 centimeters in this case. I didn't show you the transeptal, but he had a lot of septum. We had good height. I could not grab at that point. So on your image on the right, you see me moving laterally because I felt like I was more able to grasp easily in a lateral sort of, A1, P1, or right at the border of the A2, A1, P2, P1 zone. So that's what I did. I did that, and my first clip was an SLDA. So now you see in this image, a second clip has come in. And for reasons which we can get into, the second clip actually was deployed where I had tried to deploy my first clip, right at A2, P2. And for a reason which I'll go into later, it actually was easy to deploy that second clip right at A2, P2. I think the fact that the first clip was on that posterior leaflet did something to sort of help me to grab it more easily, but I was able to deploy a second clip right at A2, P2. It didn't make much of an improvement in the degree of MR, but I felt comfortable that, okay, I've at least stabilized the situation, and I proceeded with the case. So these are the 2 clips so far. The one that's lateral is the SLDA. The second clip is the A2, P2. There's still a ton of MR. It's obviously, you're seeing a PZ at a normal aliasing velocity, which is never a good sign. And it's highly eccentric, as you can see in the image there on the extreme right. So now there's 3 clips. The third clip is more medial. And so we have 2 successful grasps, 1 lateral clip that's an SLDA. At this point, going on with the imaging. There was a significant regurgitant jet laterally, and I felt like there was no way I could leave the patient with that result. So I introduced a fourth clip, but I placed it in that lateral location. Somehow, with some difficulty with imaging, we were able to actually have what we felt was a confident grasp at an A1, P1, or near lateral commissure location. So this is the fourth clip, which we subsequently deployed. Here's the fourth clip deployed, and you see the image on the right has 4 mitral clips, one of which is the SLDA, and the other 3 clips, which we felt, had good anterior and posterior leaflet grasp. So we have a mean gradient of 7 under the TEE, and this is our final result. And I felt like, okay, it's a reasonable result in terms of regurgitation reduction, but I'm obviously concerned that we've caused a significant gradient. At this point, the case had gone on long enough that I said, okay, I think it's time to stop, and let's see how the patient does. This is his post-op day 1 echo. Much more regurgitation than what we had left the cath lab with the day prior, so I was surprised to see that. A part of me is always going to be curious whether the fourth clip that I placed in the lateral commissure truly was an adequate grasp or whether it was an SLDA just like its neighbor, but I'll never know. But clearly this is much more MR than what we left the lab with the day before. His mean gradient on transthoracic was 9. I'm sure many of you find that it's a point or 2 higher, a millimeter of mercury, 1 or 2 millimeters of mercury higher than always on the transthoracic the next day. So he had ongoing symptoms, O2 requirements, required progressive oxygen escalation, and ultimately on post-op day 5, the patient's family decided to pursue comfort care measures due to lack of any improvement, and he passed away in a sleep on the night of post-op day 5. So what are the learnings? In cases like this, I feel like since this case, which was about a couple years ago, I have changed my approach to these kinds of patients. Less is more. First off, I still do what I did in this case, which is to have an extensive discussion about whether anything should be done at all. And many times we choose not to do anything to these types of patients, but if you are going to do something, I think this is a case where if I had even just cut the MR in half with 1 or 2 clips, that might have been the best achievable result for an anatomy like this in this particular patient, rather than trying to reach for the sky or reach for the stars. So I think less is more was one takeaway. The other takeaway is that, trying everything you can to be disciplined, to really grab in the area that you originally instinctively wanted to grab is always advisable, because if you adapt to try a different strategy and you have compromised imaging, you're going to regret it, because that's what happened in this case. We moved laterally and we didn't have adequate tissue quality or imaging quality to really be confident in that first grasp, which then set the tone and the ricochet of events for the rest of the case. And then I think transeptal, proprietary, commercially available transeptal, transcatheter mitral replacement devices, as well as mitral clip removal systems, will be vital in cases like this, which happen, I'm sure, every day around the country, where these types of cases would need some sort of transcatheter solution with the ability to remove these clips. So thank you.
Hey, Rahul, that's a great case, and thank you for sharing with us. And, I think, we probably learn more from these cases than, the shiny, perfect ones. Like this is, the things we struggle with every day. And I just wanted to ask, how many people have used 2 guides for, these really difficult cases to grab? Yeah, 2 MitraClip guides. 2, hands, you know what I mean? Well, I think I've done it once, but I've heard about it, that, you have a guide in each groin, and you either share a transeptal and make it wider, or do 2 separate transeptals. And if you can't really successfully grab both leaflets, even with the independent grasping now, you could do a partial grasp of one of the leaflets and stabilize it, and use the other one and just hold it in place, and like you would do with adenosine, but maybe if the adenosine wasn't working for you, and then use the other one to grab, and then you have the other one, right adjacent to it, and then you can close both clips without releasing. Actually,
Right.
It's
I
just
think-
very expensive.
Yeah, I think it's a very interesting idea. I've never thought of that. I mean, I understand the mechanical explanation of what you're saying. In this case, and kind of relevant to some of the cases that we've seen here today, all of us practice in political ecosystems where there are varying appetites for some of the things that you see at conferences like CVI. And some of us practice in hospitals where there is no appetite to do some of those things. I would say, very thoughtful about whether I should even engage with this patient. I remember this case vividly and always will. And I don't think trying something creative like that, which sounds very intriguing in someone like him, would have been a politically viable strategy in my hospital. But I think for a patient like this, my approach has and will be forever that, as simple as possible of a solution, as minimal footprint as possible of a solution in terms of equipment and what we're doing is probably the right strategy. But you're right, Marvin, the anatomy, will be limited, or what we could do with the anatomy will be very limited if we constrain ourselves to those parameters. But that may be a sign to just not do anything.
So based on your question, Marvin, it's fair to assume that the bar's been open for a couple hours already?
It's kind of like a MitraClip monkey bar concept,
But I mean, it's actually interesting not just for mitral, but tricuspid too. Almost anywhere where you might have trouble grasping, you could consider two guides. All right, so next, CVI 2025. One of you is going to show a case. I'm quite confident.
It'll be a two-guide track.
Two-guide track, yes.
Yeah, absolutely. Right. Yeah. Yeah.
And then the second part was about the two guides. I have thought about it in cases not like this, but in a case where I could grab it, but there is still severe MR and the vein is 4 to 5. Like, what will happen if I release this and put a second clip? I almost did it once. Like, just leave this clip on and then put another guy and see what happens with the second clip when the vein is 10 and take everything out of this the patient surgery.
I had a quick, sorry. For a simple surgeon, I had a quick question about the clip removal device. How often do you wish you had something like that? Like, how often does that become relevant?
I personally would say rarely. I had to dig deep to find a case that didn't go well. This is what Paul asked me to do. All of my cases go great. But yeah, no, I think once every 5 years I might, need. Yeah.
But there are, if you look at TVT registry, there are a lot of MS cases, there are a lot of people. So I think it will be useful. But then a lot of the valves also hang on the leaflets, so it's not just you take it out.
Yeah, I think it's not so much at the time of the edge-to-edge repair. It's later on when patients that have had previous TEER come back with recurrent MR, and now they are not amenable for whatever reasons to further TEER. Those are probably the scenarios where I think it's going to be most utilized.
So we tried the two guides for tricuspid, and they're not for mitral but for tricuspid. The challenge with it is, one is probably one of the reasons why you needed two guides, because difficult grasp, difficult imaging. You just made it harder when you have two guides in the atrium. Now imaging is more shadowing, and then you lost your ICE access, which is what we turned into the second guide access, and then if you need ICE on top of it, then you're talking about double sticking, one of the veins. So I know it is attractive, and the concept of incremental grasping of the leaflet is also attractive, but it comes at a cost, not just financial. It is not as easy as, especially for tricuspid. We never tried it for mitral, but the cases that we've done, you just turn into a blizzard storm that you can't see much.
So in your case, did it work? The double guide for tricuspid?
So it works. The device that we questioned at the beginning was actually the good device, And the second device that we use to anchor on it is the one that we could not be confident with. So so we end up doing one with one guide, and then the other with the second guide, and the third with the first guide.
Was that Pascal or Trico?
It was Pascal.
So this reminds me of a case I was involved with several years ago, where a patient, I can't recall the scenario, but they were on support, either a tandem or an ECMO. And we were able to manipulate the flows on ECMO to get the leaflets closer together. Is there ever a role for, I don't know if the balloon pump's going to be enough to do that, but more support in order to decompress the heart while maintaining blood pressure?
Yeah. So actually, I mean, I routinely in my FMR, low EF FMR cases where we've had discussions interdisciplinary about TIR versus considering transplant options, if we're going to go with TIR, when I start the case, I'll check an EDP, we'll look at dimensions. If we put an Impella in, and obviously prior to the procedure for days, the patient's been diuresed as well, I have seen visually in the case, decompression to assist, Impella assisted TIR in those really low EF patients. But I have no experience with tandem heart doing that with tandem or with anything. Right. Yeah, and I guess depending on the mechanism of the dilatation, if it's more ventricular, ventricular unloading would probably be, but if it's like more like an atrially mediated thing, then something like tandem might be the answer.
Yeah, great.
Oh, it would have been simple. I would have just done a sternotomy, just replace the valve. A couple hours.
He would have blamed the cardiologist.
Just another day at the office.
A sliding angioplasty.
All right, excellent. Good. Is Scott here? Great. So next case is Neo-LVOT Management by Scott Chadderdon.
Okay. Well, thank you all. It's 5 o'clock on, what is this, Thursday? We're all still here. This is great. So thank you for being here. Thank you for the invitation to present. My disclosures are not enough to fit on this slide, so I just didn't put it on there, so you can look those up. My other disclosures, I work at OHSU with Faraz and Hirsch over here, so yell at them. Reason for evaluation for this case, 88-year-old male, severe shortness of breath, class 2 progressing to class 3 over the past 6 months. Echo shows severe mitral annular calcification, severe mitral stenosis, oh my lord, peak gradient of 28, mean gradient of 17. I mean, these are the highest I've seen. I don't know how this guy was handling this for so long, but it tells you about the chronicity of it for him. It had a TAVR about 6 months prior in a center about 5 hours from us. He wasn't improving after TAVR, so they referred him up. Pre-TAVR, he had a PCI to his LAD and also had a pacemaker after that TAVR. So baseline imaging here, normal LV systolic function, normal LV size. You see the severe mitral annular calcification. You see the large gradient. Short axis, you can see it's pretty well circumferential. There's bulkiness of the anterior leaflet as well, and calcium up to the base of the aortomitral curtain. TE imaging shows similar features. Again, this is native mitral valve, severe MAC, mild mitral regurgitation, mean gradient here 15, planimetered valve area right at about 0.9 to 1. And you can see just this diffuse calcification across the leaflets and circumferential. Despite this, pretty reasonable hemodynamics. I'm pretty surprised that his mean PA pressure was only 22, no pulmonary arterial hypertension, cardiac output in the 4s. So we thought, okay, the only pathway forward for this gentleman for treatment without, in the absence of mitral regurgitation was for a valve and MAC strategy. So you can see a CT was done here. You'll see the CT analysis and the representative pictures on the side of the screen, both in diastole and in systole. You'll notice the bulging basal septum there that's measured at about 15 millimeters. And then with a 29 S3 as a part of the implant strategy, a very small LVOT, a reasonable sized skirt Neo-LVOT, and you can see the dimensions there. So on further analysis, you can see in peak systole here, just kind of obliterating the LVOT. Put that on silent. That's my nurse calling me. And you can see here, anterior leaflet length, about 21 millimeters, and the valve projected into the ventricle about the same distance. So, LVOT techniques. I think we've hit a bunch of these, actually probably all of these this afternoon. Alcohol septal ablation, radiofrequency ablation as well has been used. People have touched on Sesame, Lampoon, other valve and valve strategies. So I thought I would pause there first and get everyone's aspect and what your plan would be.
Does the patient's coronary angiogram show good septal perforators for septal ablation?
It does, yes.
So I would say alcohol septal ablation followed by valve and TMVR.
Okay. Other thoughts, other strategies? Yay, nay, sesame, no sesame.
I was doubtful about the Lampoon, but on the CT, it looked like there was a spot you could cross. So I would have done the belt and suspenders thing and done an alcohol septal ablation and a Lampoon, or attempted a Lampoon, because in case the Lampoon doesn't work, then you have at least done it, something to help yourself out.
Yeah.
I'm not sure we'd be able to do a Lampoon based on what we saw, but I think doing the ETH up front.
Okay. Reasonable strategies. Anyone else want to take a hit at it? Sesame, no go. He's too old. 88. No. No way. So we started with the alcohol septal ablation. So this was a CT about 6 to 8 weeks after the septal ablation. And I apologize, I'm not an angiographer, so I didn't show that. I wanted to focus on the multimodality imaging. But it seemed to have worked. Look at this. Basal septum now and diastole down from really down about 5 millimeters. We talked about the amount of alcohol for this. Really only 0.3 cc's was given for this reduction, and it improved our frame Neo-LVOT, but still a little tight, 108. Didn't make much change in the skirt. So now what? Do it, don't do it? Well, it's Oregon Health Sciences University, and it's Dr. Goel and Dr. Czar. So we planned to go ahead with it, and we planned this with a Lampoon procedure for that length of the anterior leaflet. We thought that there was some basal areas that we could get through. So transeptal puncture, you'll see here, we got a reasonable amount of height for valve and valve. So on the left is our positioning of the catheters, at the base of the anterior mitral leaflet. You'll see we electrocauterize there, able to get through. We're able to create our snare and loop on the right-hand side. Then on the left upper, this is the initial electrocautery and pulling. And it'll keep playing. And you'll see a nice, slow, steady movement of the catheters. You'll see on the right-hand side, then it popped through. We've created a fissure and a laceration from the base. You know, it followed the angle of mitral the angle of the calcification across that anterior leaflet there. But since it was so central and it pushed both of those arms out of the way, we thought this would be a successful strategy. Then the next part was access with the 29 S3, slow inflation, lovely landing, no paravalvular regurgitation, complete round valve in place in the annulus, a little bit of leak just from the wire. Job's not done there. What's the gradient? So here you can visibly see that the stent struts kind of cover the LVOT. You can see the flow going through the stent frames. There's a big flow acceleration there. Visibly in your transgastric, you can see both the narrowing of the LVOT flow going through the LVOT, but then through the stent frames there as well. And in a transgastric alignment for gradients, peak gradient of 30 and mean gradient of 18. But you do hemodynamics, and what does echo pick up? Echo picks up velocities, right? The velocity is accelerated through those stent frames. That's not the pressure gradient the ventricle is seeing. Pressure gradient the ventricle is seeing is about 10 millimeters of mercury. So I think our peak difference there was 7 or so. So pre-procedural view planning for LVOT management, what do I think are keys? Consider all strategies. Consider, if you need to walk away. I don't think that's unreasonable when you're doing high-risk procedures. Ablation, ablation, ablation from other cases. If you don't succeed at first, try again. Do another alcohol septal ablation. Go to radiofrequency ablation. Think about anterior leaflet modification. Look at the base, see if you can get across there from base to tip for splitting. It will follow that calcification. It's not predictable, but you could probably predict it based off of where you're getting your first catheter in. Flow acceleration is different than hemodynamic impact on the LV. And I think the most important thing is make sure you have a great echocardiographer to guide the procedure.
Absolutely fantastic case. So question. Question for our panelists, Paul, the audience. So let's say in a case like this, you've finished, you're done, and you went and checked your pressure gradients, but it was significant, and it mimicked what the echo was showing. At what point do you balance between removing more septum through a variety of other ablation techniques, RFs, sesame, whatever, versus trying something, Paul, which I think you've done in the past, where you went in and inflated a balloon, if I'm not mistaken, in the LVOT to sort of turn that ventricular aspect of the sapien frame into a D?
I'll tell you what I think, and I'm not an interventional cardiologist. I think if the patient is hemodynamically unstable, you do something, but if they're hemodynamically stable, they can tolerate aortic stenosis. Now, what you do for the hemodynamic instability, I think, is a great question, but I wouldn't react based on the gradient. I'd react based off of how they are extubated once they're beta blocked and what their medical therapy is. So, look. Faraz, how would you have thought about this case if you were doing it?
Is there a way you can go to the slides? I want to just, your third slide, the CT. I have to admit.
Can we go back?
go to the the second or third slide, the baseline CT.
If you can go backwards on it,
Yeah,
or if I can.
Yeah, that.
Keep going
This-
backwards, maybe about
Right
four
after
more.
his disclosure
Yeah.
paper.
Another one.
And
That's
back.
post. Yep. One
So-
more back. One more. Perfect.
No, yeah, so that's actually good enough. So if you look at the hockey puck, view there, and I think that this is something that driving up, that morning, we saw the Batman logo on OHSU projecting all the way from Minneapolis, Paul, and we said, should we do Batman in this case? And I think the fear is, that in case like this where the calcium is even at the tip of the leaflet, that you're going to be longitudinally taking it across the anterior leaflet as opposed to slicing it, to the middle. And even with Lampoon, it was very slow, multiple, a lot of control over the agilis, both agilis, as we pull, so we make sure that we go to the middle of A2. I mean, the fear if we do a balloon-assisted procedure here is that we might slice the leaflet in a way that doesn't necessarily help us in the direction, especially with that pattern of calcification on the anterior leaflet.
It's incredibly hard to predict these things. And so, Scott, I mean, I want to ask you, when you say predict the split, how can you look at that and predict the split? And then not only predict the split, predict the splay of the anterior leaflet with the sapien in. Because we had a case about a month ago, and the patient unfortunately died. And it was very similar anatomy, where we went in and we lampooned, but the anterior leaflet was just too bulky, too calcified, and part of the reason why she obstructed was because it just didn't splay once you put the sapien in. So how do you predict that split and splay? And then, because that's the same question you're asking me, how do you predict where the Batman's going to go? Because the risk with Batman is the leaflet tips do not break, and everything actually tears up into the aortic root, which would be an absolute disaster. So
I mean,
how do you?
why our strategy always involved a septal modification. I mean, all of those cases, we start with an alcohol septal ablation, regardless of whether or not the LVOT is borderline or totally unacceptable.
I'd like to think I was smart enough to say that I know how to predict the split. I think I'm not sure if there's a algorithm for that or not at all. But looking at that leaflet and seeing the directionality of the calcium, you're just not gonna fight over that. It's not gonna go likely through that. It's gonna want to take the path of least resistance. So then it becomes, well, what kind of guiding pressure can you use from the groin with two catheters and electrocautery wire at the same time? I don't know. But I think if there's registries of more and more of these, and we're capturing the 3D aspect of it, we might be able to develop something. So, as more and more of that's done. And I'd love to learn from others what their experience has been.
Yeah, I mean, okay, let's pretend, we saw this case where we hit the rewind button and went, oh, okay, let's try it again. Mm-hmm. I guess one of the variations you can try is you could do a balloon-assisted lampoon, which is like, you create your rail and you take like a 5 mm balloon, and it's supposed to extend, the splay. So I think they did some benchtop testing at Emory, and it's supposed to increase, for both Basilica and Lampoon, increases the splay like 20 or 30%. Now, I've done it once, and that's probably a case I should present next year, and we can talk about that later. And then the last thing is you do have a sapien valve. So let's say if you did do Batman and you couldn't predict which way your balloon was going to bias in the inflation, at least you have something that kind of buttresses the aeromitral curtain, so I think it would limit your split. Now, that's a theory, right? So I would have been more comfortable if that was a surgical valve, and I was certain that whatever was there was scarred in, and your balloon couldn't wreak havoc in the aeromitral curtain. But I do think that because you have you have that TAVR valve there, that you probably could have done a Batman, and maybe inflated with at least a 14 balloon. and maybe you would have had a better LVOT gradient as a result. Ultimately, what you have is at least survivable. So if you recall from the Lampoon trial, like, the whole point of the Lampoon was to, get out the case with a survivable gradient, not the catastrophic LVT obstruction that you used to see in like the mid, 20 between, like in 2015. You use a peripheral balloon?
Yeah, but
Coronary shockwave.
4 or 5 4 millimeter balloon. It's basically just playing the bass.
Right.
So first take a 3O balloon, open the thing, and then take a shockwave. Theoretically, you can use a larger one, 7. You can use a larger one.
Yeah, like the
Because it's a calcified leaflet. If it's not a calcified leaflet, then obviously Batman or something else would work.
yeah. Because the little holes are very well tolerated. Like, the MOV MR, even though it's severe, they actually tolerate pretty well.
All right, good. We got one more. Thanks very much, Scott. So the next and final talk is another boundary cross for transcatheter mitral therapy by Anene Ukaigwe.
Okay, thanks to everyone for waiting this long, and thank you to Dr. Sorajja for having me in this session again. So I have no disclosures that are relevant to this talk, and I'll be sharing a case of a 79-year-old lady who was transferred to us for redo mitral surgery for severe paravalvular regurgitation of a mitral prosthesis. So a little bit of background. She'd had mitral valve replacement about a year ago with a 27 epic biocore. She had severe mixed mitral valve disease, secondary to mitral annular calcification. So she said she felt well for about 4 months. After 4 months, she felt well. Then about 3 months prior to this presentation, 3 episodes of heart failure hospitalizations, 2 of them required transfusions. And another thing was that she had neurogenic bladder with recurrent catheterizations. So because of a concern for UTI, she had a urine culture and blood culture that both grew Klebsiella pneumoniae. The Klebsiella cleared within 24 hours of antibiotics. But she did have a hemoglobin of about 7.4, peripheral Smith that showed schistocytes, AST, LDH, bilirubin. They were all elevated, and undetectable haptoglobin, all consistent with hemolytic anemia. So this is our esophageal echo, and we can see that she has severe mitral regurgitation that appears to be predominantly posterior, also extending a little bit laterally with mobility of the mitral prosthesis. And this is a 3D rendering, and we can see from both the top panels, which are 3D renderings from the left atrium and from the left ventricle, that she does have a significant involvement of the circumference of the mitral prosthesis that would equal greater than a quarter of it. We assessed this based on CT scan, and again from the LV portion of the mitral prosthesis, and it extended to about from 4 to about 8 o'clock, about 40% of the prosthesis. So this was the first part of the issue. So as part of the multidisciplinary discussion, the first thing was that the cardiac surgeon said too high risk for recurrence of the PVL due to the MAC, too high risk for reduced stenotomy. Now, the infectious disease specialist, and I learned a lot more about Duke 2023 criteria that I knew before this case, was that in the presence of bacteremia and there is paravalvular regurgitation, it is presumed endocarditis, and that patient should have surgery. Now, from our perspective, from interventional cardiology, we should not be putting plugs where we think there's active effective endocarditis. And if there is a significant involvement of the circumference of the annulus, then should be concerned about stability of paravalvular closure by transcatheter means, and therefore that is, by some expert recommendations, not ideal. So went back and looked at her CT scan, and we showed that she did have mitral annular calcification, which was not as severe as some of the cases that we've seen, but was there. And then looking at her intraoperative TEE, she did have MAC that extended to both the anterior mitral leaflets. So the right panel was before mitral valve replacement, left was after, and although there was excision of the leaflets, there was still no significant decalcification procedures per the op report, so we felt that that was probably it. We had to reconvene for a multidisciplinary discussion, and from the surgery perspective, they felt that, paravalvular regurgitation is a tissue friability or tissue integrity problem, and they thought this was more likely due to MAC. We rediscussed this with infectious disease specialists, and they agreed that we could do a transcatheter closure as long as the patient was on suppressive antibiotics. And from an interventional cardiology perspective, although there was mobility of the leaflet, of the prosthesis, it did not appear to be more than you would expect from a mitral prosthesis that has discontinuity from the mitral annulus. So we agreed to attempt closure after antibiotics. So at this point, I just want to hear what people would have done in this case. What kind of plugs would they have picked? How would they have selected sizes? What access would they use? And would they do sequential or simultaneous deployment?
So, those gaps look pretty big. I probably would use AVP2, and I would do a transseptal approach. And I tend to use simultaneous deployments because to the other people's points, like when you have multiple wires in and they get crossed over, like it's hard to maintain a parallel arrangement of your interventional equipment. So I find that if you try to deploy them simultaneously, the plugs space each other out evenly. So that's how I normally do it.
Yeah.
I think this is very brave to plug this, and so I think, bacteremia, I probably would have taken this woman as surgery. And, you can always remove more MAC and try and get more of a circumferential, bigger size valve in the second time around. It may not go so well, but, that's what I would have done.
Yeah. But assuming that's not an option, I do agree that a larger sheath, like an 8 through a Destino, have wires in there. You can put as many as you want in theoretically with buddy wire. And I like keeping them tethered until the end as well. I think that's what Marvin was getting at, so you can release them essentially at the same time.
I would do a hopscotch. So I would do a hopscotch approach. That's basically where you double wire and you take one wire at a time and
Right.
march around the
Yeah.
valve, always keeping 2 wires in place.
Oh.
I think you're going to need at least 5 or 6 plugs, and you're not going to be able to deploy them all at the same time.
Why? Explain that, Paul. Why 2?
So basically, the hopscotch is 2 wires.
Yep.
And basically, you're just going lateral to medial. You're taking out the one that's lateral, moving it to medial. After you put the
Oh,
plug,
yeah.
you just go around.
Yeah, exactly. Same thing I was talking about. So that's good. Yeah, it's a cute name. Thanks.
What about speaking of rail? The problem with the rail is you can't hopscotch it.
Yeah.
So, but this is a big camera. I think you should be able to wire it sequentially.
And do you typically use a Destino sheath so you can get an 8-French shuttle in, or yeah?
You can do it in a jealous.
And use a 6? It's true. Yep. Yep.
Okay. First, you're all smarter than I am, and second, Dr. Sorajja, I need to. I'm going to blame you for this because you did not teach me the hopscotch. So what I decided to do was AVP plugs, like was earlier mentioned, thinner braid, less hemolysis. AVP2 is available in the United States. And I was going to do a transeptal. I planned to go mid because I felt it would give me enough room to navigate around the segment posteriorly. I was going to use a vein arterial rail. I planned to do it sequentially. I wanted to get a feel for the tissue first. And I was, with respect to sizing, I was going to use the larger size to cover the defect, but not interact with the prosthesis. And it's amazing that, for practically all transcatheter procedures, except maybe edge-to-edge repair, you can plan ahead of time. For this, you can't. So I use this very rudimentary method where I take a picture of it in a PowerPoint and put circles that help me decide what size plug I'm going to use. So for this, the 16s were a little too large. So I was going to do 2 14s and 1 12. So transeptal went as planned, and I went with the venereal rail snared and exteriorized from the left femoral artery. Went in with an 8 French shoulder sheath because I wanted to leave the wire behind and go through that. First 40 millimeter plug went great. And the wire moved laterally, so I went with the second AVP plug, and exactly just like Dr. Sorajja predicted, now I have a wire that's in between both plugs, and I have a lateral jet that is residual. So at this point, I had to decide: do I want to retrieve and rewire, or do I want to retrieve and restart, or do I want to rewire? Although it was a very small hole, I decided that I didn't want to lose what ground I had, so I tried to rewire it. I was eventually able to cross it. It was difficult. We could barely see, and I had to use an MPA catheter to confirm that we were truly through the defect and not through the valve. And after that, the third 12 millimeter AVP plug. At this time, I didn't use the VA reel since it was just one. And we can see that because I was pulling, I still had the cables attached and were coming medially. The plugs were directed slightly anterior medially, and so it looked like it was covering the prosthesis, but based off of my previous assessment, I didn't think this was going to be the case when the plugs were released. They were all released. And if you look at the top left and right panels, the left with the cables, the right without, you can see that the plugs have now fallen back and away from the prosthesis and not encroaching on the orifice. Mitral regurgitation is reduced to mild, and patients feel pressure. So her V wave went from 71 to 28 with a mean from 34 to 17, and that initial pressure was after 1 week hospitalization for optimization. So out of 5 months, no further hospitalizations, no transfusion, not on oxygen. She actually skipped my appointment to go to her grandson's graduation because she felt so well, but infectious diseases saw her and felt that she was doing remarkably well. No lab features of hemolysis anymore. So the key learning point is for this patient, multidisciplinary team discussions for individualized care that includes infectious diseases and multimodality images, both retrospectively and in real time. Extensive PVL can still be closed percutaneously, and the strategies for planning, sizing of plugs, simulating closure are some areas that we'll probably need to work more on. Thank you.
Very good. Killer case. Excellent. Killer.
I just wonder if you overestimated the circumference of the leak initially, because when you look at your plugs, you're not covering 40%, I don't think, of the circumference. And it can be easy to do that because the spray of the MR, can spray in all directions. So I think there's another word for it, the high velocity filter, but there's some other technical, can maybe, really hone down on what the origin of the leak is. But I wonder if it wasn't really quite as extensive as you thought.
I mean, that's a fair point. We estimated the extent of it. That's why we use the ventricular side from the 3D rather than the atrial side, because the atrial side you can't really tell with what direction the gradient goes. So we try to use the 3D measurements or estimates from the ventricular side, because there we felt we could actually see the PISA of it.
But you still had excellent V wave reduction. I mean, that's fantastic, 70 to 28. So definitely obliterated a fair amount of MR.
Any other questions or comments? Shall we wrap? It's not a bad way to wrap it up. It's a very nice case.